Dear ladies and gentlemen, dear chairman, thanks very much for being at the conference. I've been really honored to be at the ANZSNM 2022. Unfortunately, not in person due to still some issues of COVID-19 and travel restriction. However, I'm happy to join the meeting and share with you a new perspective in staging and theranostic using FAP-ligands. Here are my disclosures. So before I step into the translation into nuclear medicine and their applications, I would like to go a little step backwards where we stay and what we have been going through in the last, so to say, 5 years, and where I do believe that nuclear medicine is on the way of this new big oncological avenue. When we look to the past, radiotherapeutic iodine-131 for thyroid cancer has been well established, and in all clinical nuclear medicine, then paced further by a rare disease with neuroendocrine cancer with the Luther trial is now been also approved by the FDA in the US. Just recently in prostate cancer in March 2022, also PSMA lutetium treatment is now available for patient care in the United States and also foster the way of theranostics. Today I would like to really share with you something that's going beyond PSMA, going beyond also a one tumor entity, and it's a target of cancer-associated fibroblast, also called FAP-ligand. So FAP is something where we are addressing microstroma and microenvironment, and that is going beyond one tumor entity if you compare it to PSMA, where we're addressing prostate cancer, or when we compare it to DOTA-TOC, when we address neuroendocrine cancer patients. So it seemed to be that particular FAP-ligands is a very generalized target, and it's even going beyond cancer diagnostic and treatment. So before I go deeper into this application, I really would like to go and make a step backwards to what is cancer about and where we also can explore and find cancer-associated fibroblast. So first of all, when the tumor is growing and the cell cluster is getting larger and larger, we are dealing, of course, primarily with cancer cells, and the investigation of cancer genetics per se was in the past a very important. We also have applications in treatment and cancer understanding. However, when cancer is growing and enlarging, cancer itself in the microstructure needs supportive cells, for example, fibroblasts, immune cells, endothelial cells, and of course also stem cells. So in the whole overall picture, as a bird view, so to say, we're really dealing not only with just only cancer cells. We are dealing, when the tumor is growing, also with the stroma, and the stroma might also impact certain treatments like immune therapy, because the stiffness and the tightness of tumor is responsible, particularly and driven by cancer-associated fibroblasts. So here the message, first of all, is cancer cells are not alone. Cancer interact with other cells, and together with this, they're formating the microenvironment. And one important cornerstone here is that cancer-associated fibroblasts seem to be an important factor of growth. Cancer-associated fibroblasts generating a specific extracellular matrix, and they impact, unfortunately, in a bad way, patient survival and also the aggressiveness of tumor. So there is, at the end of the day, a dialogue between the cancer cells, but when the cancer cells enlarging and have a certain larger size, then they're needing supportive cells, and these are known as cancer-associated fibroblasts. and their major emitter is TGF-beta, who's stimulating even more cancer fibroblasts. In the normal healing process, you have already fibroblasts available, and these are called the normal fibroblasts. The normal fibroblasts are responsible for connective tissue, supportive function, and production of collagen and wound healing. However, when they're converting to cancer-associated fibroblasts, so to say the bad guys, then this is very different in the avenue of further growth and involvement of cancer enlargement. In particular, they are responsible also for metastasis and carcinogenesis and, of course, tumor infiltration and invasion. Here, schematic and more rather clear plastic simulation and a clear visualization what tumor fibroblasts are converting to. So in a normal setting of cancer cells, you have the normal fibroblast, and by triggering of TGF-beta, it's converting to the bad guys, so to say, the cancer-associated fibroblast. In this nice staining, what you can see here, normal colon tissue has no findings of any cancer-associated fibroblasts. In the opposite, if you stain against this FAP, then you see in colon cancer you have a really high involvement of the activity of cancer-associated fibroblasts. Therefore, Dvorak was stating in the mid of 1980 that wound healing and tumor is really very similar, and he stated that tumor is, so to say, a never healing wound. When we're talking about microstructure, and as you see here, then you nicely can admit that at a certain size of cell cluster of cancer, there's a high pressure of changing the microenvironment. And we know that by 20 years ago, when neoangiogenesis has been also heavily discovered and investigated for also treatment effects in cancer growing, that also cancer-associated fibroblasts will be more and more recruited and activated in a certain tumor size. And they have, of course, important emitting factor. Particular one is TGF-beta, but also they are immune suppressive. And therefore, the conclusive is that cancer-associated fibroblasts seem to be orchestrating the composition of malignancy. And here's a nice also review article if you're interested to even dig deeper into that. And a few years ago, the group in Heidelberg and Thomas Lindner, Professor Haberkorn, and myself have been really thrilled and excited to really dig deeper into the topic of tumor microenvironment and addressing particularly the cancer-associated fibroblasts. And by developing small molecules addressing the FAP receptor, it was been able to visualize non-invasively tumor microenvironment and, of course, also cancer-associated fibroblasts. With this success in preclinical, we have been translating it to patient care and comparing it, of course, with the gold standard with FDG. And if you really now comparing FDG PET on the upper row compared to FAPI-PET in the lower row, you really can appreciate that you have really similar findings. If you just, for example, see the second line where you have here an esophageal cancer, you see this black spot here in the cervical chest area, but also this can be confirmed on the FDG PET scan. The only message here is that we definitely have different surrogates. On the upper row, we have metabolic analysis of tumor, and on the lower row, we are really identifying the involvement of cancer-associated fibroblasts. And that's very different, but at the end, it's the same message. We can non-invasively make cancer visible. Also here, the comparison of SUV values was interesting to see that we have a similar corridor of normal uptakes compared to FDG and FAP. At that time, in around 2020, here a nice article that also investigated a direct comparison of FDG and FAP from a Chinese group, and they even correlated with histopathological staining. And as you nicely can see here, in that case, that this liver cancer has not been depicted by FDG, while with FAP it has been nicely visualized. So therefore, they stated that FAP-PET showed superiority diagnostic efficacy compared to FDG in primary and metastatic lesion in patients of various cancer types. Also, we in the Heidelberg group can confirm the same pattern, that in certain cases we even have a stronger signal to background in, so to say, PET scanners. If you compare the left side of a patient with colon cancer, we even see the knee lesion very nicely and even the metastatic spread, while with FDG rather moderate visualization. And also here with the pancreas cancer, where this will be always challenged by FDG, with FAP-PET you nicely can see even the primary tumor. Similar can I really present here was another patient with a primary pancreas cancer, as you visualized here in the FAP-PET, and also unfortunately liver metastasis, which also been depicted nicely by FDG, but the primary tumor has not been depicted by FDG. And here another case which also really thrilled me when I'm presenting this. This is a patient where you really see only minor tumor involvement in FDG on the left side, and on the right side you see even micrometastasis metastatic spread using FAP. So really it seemed to be particular in pancreas cancer, FAP-PET scan might be the imaging modality of choice in the future. And also this is being confirmed by staining, and as I mentioned in the introduction, with tumor aggressiveness we have a high involvement of cancer-associated fibroblasts, and what you see here in the brownish staining, that the FAP immunohistochemistry presenting a very strong reaction of the stroma and the involvement of cancer-associated fibroblasts, that we are now able. We then also 2 years ago investigated the possibility of certain tumor entities, and we have been also interested in which cancer might be more expressing the cancer-associated fibroblasts compared to cancers that even rather on a moderate or lower row in regard to cancer-associated fibroblasts. And you see nicely that you have some leaders in regard to CAF expression, like for example lung cancer, breast cancer, or even CCC, while on the other side you have cancer subtypes like renal cell cancer or thyroid cancer. They rather are on the low side. However, I still have to admit it is surprising to me that due to the really low background, that even this minor uptake really presents in a clinical routine with very great tumor to background ratios, so beneficial ratios that also perform and outperform in diagnostic efficacy compared to probe on B. So as you see here, and this really confirms that we have here a tracer that is only not applicable in one tumor subtypes. It is applicable to various cancer subtypes, going from sarcoma via breast cancer, lung cancer, ovarian cancer, colon cancer, and finally also to prostate cancer. We also investigated in a multi-center institutional trial comparing FDG and FAP in an intra-individual comparison. And here you see the case with a patient with liver metastasis. And what you see with the FDG, you have a rather higher FDG uptake in the liver on physiological pattern, and therefore you are challenged with small lesion of liver metastasis, which nicely been depicted and visualized by FAP PET scan. And here another case where also colon cancer, where you have the bowel movement, where also you are challenged due to the situation that you have an overlap of bowel motion, artifacts, and uptake of FDG that is rather not visible in the FAP scan compared to the FDG scan in a patient with cancer. That we have been then appreciated by the SNMMI as an image of the year 2019. We are highly appreciating that, but it's also pacing the avenue that now it's over 350 publications out there already in the last 2 years on FAP investigations in clinical setting. Here, even in a rare disease situation, we investigated FAP performance, and you see also that even in the rare disease space, FAP is a very, very well appreciated tracer and also outperforming in this corridor and application. Here another case of a metastasized colon cancer was also confirmation of morphological visualization, as you see here in the liver, as unfortunately liver metastasis, but also lung involvement. And case here of a lung cancer patient, and here nicely seen, also with unfortunately brain metastasis and lung involvement, and also lymph node metastasis, nicely and depicted by the FAP scan. This is a scan where also particularly the radio-oncologist highly appreciating due to the situation that we have a very high signal to background ratio and also be nicely being applied for radiotherapeutic target volume definition. And similar to the history of PSMA, we are also having the challenge or the question of which is the best radioisotope to go for. And it also has the same similar tension between F18 radioisotope and gallium-68, but all matters at the end of the day the same kind of setting as PSMA, with the topic of infrastructure and your own healthcare setting. However, we also developed a FAP F18 labeled compound and has been recently published in JNM. This is a lung cancer patient, as you nicely can see here, that the FAP-74 was a very easy labeling two-step yielding outcome. You see nicely that we have a very strong and fast, rapid uptake in the target of lung cancer patients, even after 10 minutes. And it's not really different from 1 hour or 3 hours, which also imply that we even ready to scan close after injection using FAP, and that's also a kind of advantage compared to FDG. Here another case with FAP-74 in F18 labeled compound, which nicely can be also appreciated in the, unfortunately, this case extent really late stage disease. And this finding also confirmed by CT involvement, but some of them, like for example this bone metastasis, has not been depicted by CT morphology, and also these 3 lesions has not been defined by CT bone metastasis. But of course, with the FAP scan, we can definitely define that here we have also bone metastasis on a lung cancer patient. As I mentioned, target volume definition is also sometimes very an important topic in radio-oncology. And here you see also in a patient with a mucoepidermoid carcinoma of the parotid gland, that we have here a very strong signal to a very low background, And that really is supportive and help radio-oncologists. We also have been extended that in particular in region where we get challenged in regarding to bowel movements using FDG PET scans, and here with a patient with anal cancer also have been highly appreciated the strong signal using FAPI to really elaborate where is the extension of the cancer in certain areas, like for example also another case of anal cancer. However, what we have not been talked about so far is a question of, can we do something like therapy monitoring of a systemic disease based on, for example, treatment intervention of immunotherapy. And what you see nicely, this is a patient that has been involved in immune modulatory therapeutic treatment. And here, after certain cycles of immune therapy, you see nicely that the FAP scan and the cancer-associated fibroblast is declining in that non-invasive imaging method. And what we can imply, and this has been confirmed by also clinical outcome, that this also has been evident that patient responding to the immune therapeutic. But of course, in nuclear medicine, we also want to translate not only to be in the imaging successful, but also translate into theranostics, so treatment. And therefore, it is important to develop FAP-ligands that has a certain longer tumor residence time. If you look to the first two FAP-ligands that we have been developed, you see FAPI-02 and FAPI-04, then you see at least at the image interpretation that both of them look very similar. Unfortunately, it's not. When you look to the time quantitative analysis of 10 minutes, 1 hour, 3 hours, what you see that after 1 and 3 hours, FAPI-02 is being rapidly being washed out, while the FAPI-04 is being stable from 10 minutes to 1 hour to 3 hours. So this is some ligand that you would like to go for therapeutic. Tadashi Watanabe from Osaka, Japan, has been first described using FAPI-04 with actinium, that this is responding to treatment and that they have impact into tumor toxic. Another very follow-up paper compared even lutetium and actinium FAPI-46 in pancreas cancer, and also confirmed that the lutetium but also actinium has a tremendous effect and impact in the tumor growth, applying FAP-ligands in treatment of cancer microstroma. Of course, also we translated that in Heidelberg into patient care, and what we could find using yttrium-90 FAPI-46 at the beginning, pain release, patient converter, and also partial remission. But also we have been performing additional radioisotope, for example, samarium FAPI-46, and radioligand therapy in patients with lung cancer and sarcoma. And it also showed nicely that we have here clear, at least stable situation in regard to treatment of samarium FAPI-46 over 9 months. But also here, additional cases in a patient also with extended disease presented FAPI therapeutic success. And additional case in here of a lung cancer patient with adenocarcinoma, then started with a carboplatin and chemo and immune modulation, and followed by immunotherapy. What you see now, then after that followed a FAPI-46 yttrium-90 therapy with 7.4 gigabecquerel. Patient nicely responded to treatment. Another case here of neuroendocrine cancer patients with cisplatin and eposit and immune modulation and FAP-46 really brought and showed the benefit using FAP therapy. We have seen here tremendous lesion decline and a remission and impact in regard to tumor progression. We really see a benefit in treatment using FAP-46 FM90. But even going beyond that, we have also seen applying in diagnostic performance FAP in myocard and cardiac imaging, as you see in the preclinical setting, but there's also exciting work out there in patient and here also in rheumatoid disorders. What you nicely can see, the joint involvement of chronic inflammatory diseases. FAP can also present the disease extension. Here another case from the Erlangen group in Germany where a patient has been treated and undergoing treatment that even FAP are able to really present and show the impact of treatment success. Also a lung involvement of systemic sclerosis suffering. Here with interstitial lung disease, you see tremendous FAP uptake, and this allows us also to quantify lung fibrosis. Here another case of a patient from the Bologna group that is been also nicely presented with the involvement of lung fibrosis that is nicely being visualized by FAP scan. Of course, at the end of the day, it was a big question where FAP is going and where maybe FAP replacing FDG. Of course, it seemed to be that FAP is an important diagnostic and phenotype and biomarker role, but the question is where and will it replace FDG? Of course, you have been seeing cases, for example, in pancreas cancer and other cancer subtypes where, of course, FAP is outperforming FDG, but it will definitely not replace and even not so far as also Andre Yagaro was stating. Here a nice review article if you're keen and even dig deeper into FAP imaging. With this, I would like to close my presentation. FAP-PET is a new diagnostic imaging tool for cancer patients, even going beyond cancer patients. As you see, publication is skyrocketing on a monthly basis. It also seems that FAP is quite convenient in applying into normal routine ease acquisition and also patient preparation, because patient does not need to fasten, and also we can scan earlier. And FAP is similar to FDG as a multi-tumor tracer, but we have the option to translate not only in imaging but also in therapy. With this, I would like to close and would like to thank you very much for being invited at your convention, hopefully next time in person. I do believe and I hope you share this vision with me. FAP, the new journey that just started. Thank you very much.